Hello, everybody, and thanks so much for joining the last webinar of 2018 from Northwest W ATTC. As always, our webinar is going to be available in our website. You can see in the slide below. And also, we are offering ADA compliant recording of this presentation coming very soon, maybe tonight and maybe tomorrow you are able to access the webinar. The questions are going to be answered in the end. You have a chat box that you can use at any time to be answering your questions. My name is Bia Carlini. I'm a senior research scientist here at University of Washington, but also work at Northwest ATTC. I wear many hats on this position, but one of them is to be the webinar series coordination. I wanted to emphasize that we value your feedback on our ability to provide culturally informed and inclusive services. We are very aware as ATTC, and particularly Northwest ATTC, that language matters, and we strive to use language that are respectful of many ways of seeing the world and empowering for those people that face challenges. So please email us back if you have any suggestion how we can improve our service even more. We would love to hear from you, northwest@attcnetwork.org. And now, without further ado, I want to introduce you to Dr. Mary Hatch-Maillette. Dr. Mary Hatch-Maillette is a co-director of the Clinical Trials Network, the Northwest Node. This is a big project that is sponsored by the National Institute of Drug Abuse, and that belongs to NIH, National Institute of Health. And the Pacific Northwest Node is housed here with us in Alcohol and Drug Abuse Institute. She has been a researcher at ADAI since 2003 and is the longest serving member in the Pacific Northwest Node of CTN, or Clinical Trials Network. She has conducted many studies with a focus on HIV risk behavior, substance use treatment, and also trying to assess and intervene in the skills and comfort of counselors in addressing sexual risk with patients in substance use treatment. Without further ado, let's get it started. Thanks so much for coming, Mary.
Okay, thanks, Bia. So first of all, let me just express my appreciation for all of you who are here so close to the winter holidays. So my presentation today will be about addressing sexual risk with patients in substance abuse treatment settings. I've been working here, as Bia mentioned, at the University of Washington Alcohol and Drug Abuse Institute since 2003. Focusing on substance use treatment and sexual risk reduction and treatment interventions, and also have a private psychotherapy practice in the community. So my research interests are very much informed by what is useful and of value clinically. So my talk today, therefore, combines information that's geared toward providers, but it's informed by research that I've been involved in. And my overall goal is to give you some skills and information about talking to patients about sexual risk behavior, relationships, and communication in a way that doesn't alienate them. So just a bit of background for how the material I'll be presenting here came together through a series of clinical trials starting about 15 years ago with a pair of studies that I was involved in the NIDA Clinical Trials Network, or the CTN. And these two studies focused on how to reduce sexual and HIV risk for men and women in substance use disorder treatment. Both of the studies tested two gender-specific group treatment interventions to reduce HIV risk. One was safer sex skills building for women, and this was tested at 12 treatment programs around the country, and half were methadone programs and half were outpatient psychosocial abstinence-based programs. And then the men's protocol was Safer Sex for Men, and the intervention was called REMAS, or Real Men Are Safe, and this one was tested at 14 programs across the country. So following this, we discovered that in our data analyses that REMAS had positive results for men overall, but if you looked more closely, it was falling short with African Americans and Hispanics. So we did another project where we went through the process of culturally adapting REMAS, and so it would be more effective with people of color. And then finally, after that study, we thought, you know, we've been focusing on patients all this time. We should really spend some time thinking about how to help counselors as well, because we decided it was better to find a way to reach all counselors at agencies as opposed to just one or two that might be trained in a particular risk reduction intervention. So my colleagues and I did a training study that we just are wrapping up now with SUD treatment counselors at 4 locations in the Northwest. And I will present a little bit of what we discovered at the end of this presentation, but the bulk of the material that I'm going to talk about today takes lessons learned from all of these 4 projects and presents them in a pared down fashion so you get a taste of how to incorporate a few new things into your clinical repertoire. So with that background, the overview of what we'll be covering in the next 45 minutes or so, there's 2 main sections. Part 1 is why talk about sex with your patients, and then part 2 is how to do it comfortably and competently. So getting started with part 1. Just some things to consider as a provider or even as an agency director, both on the individual level and at the organizational level. Why would you want to discuss sexual topics with your patients in the first place? Do you open that discussion with everyone or only under certain circumstances? Do you need special training or certain background to do it well? Or do you think it's even within your scope of work, or is that somebody else's area of expertise? So these are all fair questions for any of us to ask. Conversely, you might also wonder, why would you not want to discuss sex with your patients? I mean, maybe this is a very obvious question to some of you. Why would discussing sexual risk with a patient be a bad idea or somehow not in the best interest of the person's treatment? Are there factors that get in the way of doing it successfully or that make it hard? And for many providers and agencies, it might not even be clear why this kind of topic is an important part of addiction treatment. Not to mention sex, it can often be a tough topic to discuss. So many of you see how sexual risk is very relevant in addiction treatment, and there are probably also a few of you at least who have a little more skepticism. So let me suggest that the biggest reason to talk about sex with patients is that we know sexuality and addiction are intertwined in some complicated ways. Sex can present risks to patients via sexually transmitted infections, HIV, hepatitis C. Sex can be a powerful relapse trigger and can also bring unwanted pregnancies. And thinking about the consequences such as those, you can see why the sex-drug connection is a very relevant topic in addiction treatment. So just to take a moment about STIs, we know that they're common, and about 1 in 4 people in the United States general population is diagnosed with an STI in their lifetime. So it could be something treatable like chlamydia, but it could be something that's asymptomatic, such that there's a transmission risk without the partner knowing about it. It could be something chronic like herpes, where the symptoms are managed, but it is something that the person has to deal with for their lifetime. Or it could be something like HIV, which is very serious and very treatable, but requires some specific medical treatment and to be really on top of it in order to really maintain their health. So overall, STIs are not to be overlooked in terms of their importance, and they can really present some very serious health risks. So taking a minute to just look at what our patients are doing sexually and treatment. We know that in our patient population for men, they are actually quite sexually active. And as you can see from these data, a very high percentage of men of all ages in treatment have been sexually active in the past 6 months. So of men in their 20s, over 90%, very similar for men in their 30s, still over 80% for men in their 40s, and for 50 and over, it's still 3/4 that report having had at least one partner in the last 6 months. The women look pretty similar, just slightly less active, but quite similar. Over 90% of the 18 to 29-year-olds, same for 30-year-olds. Women in their 30s, even into their 40s, the vast majority of women are quite active, and same for over 50. Thinking about, again, men and women in treatment who report having more than one partner or more than 2 partners, again, you can see it's quite a substantial proportion. So it therefore makes sense that we help our patients address this aspect of their lives in their recovery efforts. People in addiction treatment are at high risk of STIs, and I would say this is a group that does not need any additional complications in their lives. I've been mentioning HIV, so a quick summary of where HIV prevention is at currently. CDC estimates approximately 350,000 new infections have been prevented by their collective efforts since the 1980s. However, there's still about 39,000 new infections each year. And the number of new infections has been stable between 2012 and 2016, which is when we had our most recent data. And currently, about 1.2 million people in the US are living with HIV or AIDS, and about 1 in 7 of those don't know that they're infected. In terms of who's at the highest risk, it's definitely young people, 25 to 34-year-olds, and then 13 to 24-year-olds. And over half of that youngest group don't know their HIV status. So again, another look at who is most at risk. This graphic shows new diagnoses by transmission category. And as you can see, the majority of new diagnoses are occurring in men who have sex with men. People who inject drugs now represent only about 6% of new diagnoses, which is a notable reduction from in the past, when it was more like 50+%. This is largely due to the increase in harm reduction programs like syringe exchanges and public health campaigns that have really emphasized promoting safe injection practices. But notably, though, the current opioid epidemic is really threatening this progress because of the increasing number of people who've transitioned from prescription opioids to injecting opioids. So researchers are now concerned that HIV outbreaks may be nascent in communities that historically have had very low HIV risk. So again, another graphic showing that the groups that have the highest risk for new HIV infections tend to be men who have sex with men, in particular Blacks and Hispanic and Latino men, followed by Caucasian men. And then the fourth bar down are Black women who have heterosexual partners. So, and just a note, among Blacks overall, regardless of their sexual orientation, they constitute 13% of the US population, but 44% of new HIV diagnoses. So they really are bearing a disproportionate burden in terms of HIV. And this all suggests that making an effort to check in with your patients on their sexual lifestyle and risk can really translate to a major health benefit. So a couple points about women. For women, the primary route of HIV transmission is heterosexual sex. And among all women diagnosed with HIV, over half of them tend to be African American, followed by close to 20% Caucasian and 16% Hispanic and Latina. So the point here, I think, is don't be complacent if you thought that sex risk and HIV are less relevant to you as a provider if you don't see many gay and bisexual men, because for the women, their transmission risk comes in a different way, and you never know where sexual networks are overlapping. So how does all of this relate to substance use? Well, as I mentioned, HIV incidence has decreased overall in terms of drug injectors, but still it is a risk, and many believe we're kind of at a lull point and that it may be going back up again thanks to the opioid epidemic. We also know that stimulants and alcohol are important drivers in the sexual transmission of HIV. And we know that drugs and alcohol really interfere with your ability to be tested, one's entry into HIV care, and adherence to the medications that keep your viral load suppressed. And many providers also fear that drugs and alcohol will interfere with a person's adherence to pre-exposure prophylaxis, and therefore they may be less willing to prescribe PrEP, which is a problem. And we know that untreated people living with HIV and AIDS have higher viral loads and therefore higher risk for forward transmission. So can't we just tell people not to have sex while they're in treatment? That would be the logical conclusion here, and we could try. But even in situations where abstinence is the aim, we know that people still have a lot of sex. And we actually have a couple of studies that have been done that have compared two types of sex education. One was an abstinence-focused approach, and one was a more comprehensive approach. The abstinence program just really didn't cover sexuality-related content except to say, don't do it. Whereas the comprehensive programs gave information on STIs and pregnancy and relationships and a number of other topics. And from these studies, we learned that rates of sex are more or less the same regardless of whether the program says stay abstinent and don't have sex or go ahead. So that abstinence message is questionably useful or not. We know that discussing sexuality and providing safer sex information does not make sexual activity more likely. So some people have this fear that if you talk about it a lot, it'll encourage people, and that's not true. And we know that not discussing sex or not providing safe sex information doesn't prevent sex. So if you just avoid talking about it, it doesn't mean that people are somehow not going to be active and doing their thing out there. And in fact, focusing on abstinence, that message of abstinence in treatment may actually be harmful to patients because it's a lost risk reduction opportunity, and it's also an incentive for people to just not be open with you as a provider. So this can really shut down communication between patients and counselors. And this is also an important point because in 12-step models, the idea of abstinence from sex and relationships is fairly common, and our patients get that message frequently. So this idea that just not talking about it or not doing it or somehow putting the kibosh on the whole thing, not acknowledging it in early recovery is really doesn't get you to where you want to go and can backfire. So in this context, the addiction treatment context, that is, the biggest reason to talk about sex with patients is that we know the two are intertwined, and dealing with this requires counseling skills, but happily they are skills that you already, I'm sure, have, but just might not be currently using them to talk about this particular set of issues. So here are some of the things that our patients have said in terms of connections between sex and drugs or alcohol. They say that substances, they use them to have good sex or maybe just any sex. They report that substances help them to feel relaxed, disinhibited, more comfortable, to meet people. They exchange sex for drugs or money, a place to stay, or for protection. They report that substances help them deal with low sex drive when they're taking methadone, or sometimes are a motivator to go off of MAT. They also say that they have sex that they don't want while they're under the influence. And they sometimes use substances to self-medicate for sex-linked challenges or trauma histories. So if we don't connect the dots between sexuality and addiction with patients, their own feelings can become triggers for use. So if patients can learn to cope with sexuality in safe ways, they will be at lower risk of relapse. And it's also important to remember that sex can be a positive part of recovery too, not just a place for risk reduction. So relationships definitely aren't the only or the most important factor in people's addiction recovery. However, just like housing or work, they can be sources of pain and stress, or they can be areas where patients can increase stability. And having that improved stability and quality of life can contribute to recovery. So if you think about it, treatment providers, we regularly ask about employment, housing, finances, mental health, and relationships, yet we often don't ask specifically about intimacy. And I would argue that intimacy goes hand in hand with all the other major triggers that we regularly discuss. And you would be surprised at how once you start asking about this topic, it really opens the door. So don't forget that sex can be healthy. There is research that links psychological, social, emotional, and physical health benefits to sex. And it's also important to patients. In a survey of over 27,000 people in 29 countries, the majority of men, about 83%, and women, about 63%, described sex as extremely, very, or moderately important in their lives. So because it's important to patients, being open to sex-related concerns and able to help can enhance the therapeutic relationship and make providers more effective at preventing relapse. So this is the why talk about sex. Talk about it because it's potentially an area for a lot of risk. People are doing it anyway. Not talking about it doesn't make them abstinent. And being open and informative will support their recovery and normalize the sex-drug connection as just another aspect of their recovery. So I hope you're saying, this all makes a lot of sense. So what's the problem? The problem, it turns out, is that many providers are actually somewhat or a lot uncomfortable with this topic. They don't have confidence in their ability to talk to patients without offending them or opening a can of worms or seeming too intrusive, or they feel like they just don't have the training to do it. There are a lot of taboos in our culture around sex and personal boundaries, and it's understandable that in treatment settings where counselors are already so pressed for time, there are many competing issues to address, and it just doesn't get brought up. Moreover, counselors are especially trained to be sensitive to boundaries with patients, and they don't want to risk being inappropriate by talking about sex. And these are all things that we've heard counselors report to us in that series of studies that I mentioned at the beginning. So what can you as a provider do? So here we're moving into part 2 of our presentation today, which is how to have these conversations competently and comfortably. So what does good intervention here look like? It's not necessarily something that many of us learned in grad school or chemical dependency or social work programs or even medical school. So the rest of the slides present some tips for providers on what you might bear in mind when talking to your patients about sex. So the most important ingredient of everything today, and the one you will use the most, I expect, is simply permission to discuss concerns in this area. Patients take their cues from counselors, so by raising the topic of sexual issues, you convey the message that these are a legitimate part of your work together, and that can go a long way. You might want to give permission to talk about it, as well as get permission. So giving permission is something like, if you have questions or worries about sex or intimacy, I'm open to any topic you want to bring up. Getting permission might be, I have some information about sex and recovery that could be useful. Can I tell you about it? So this concept of permission aligns with motivational interviewing, which I'm sure all of you are probably familiar with, and which we'll be talking about shortly. In addition to asking, so giving or getting permission straight out, you can also do it with a normalizing statement like this one. Because so many people in recovery have sexual concerns, I bring this up with all my patients. Other examples of normalizing are things like, at our agency, we talk about sex with every new patient, or it's common to have questions or problems with intimacy in recovery. And this is really where I would say an agency can really set the tone by including this kind of topic in intake materials or in training for new counselors. This is something, normalizing is something that can be done in terms of agency culture as well as at the individual provider level when you're sitting there with your patient. So normalizing, statements that let patients know it's okay to discuss sexual issues with you. And of course, the key here is that providers normalize all kinds of stuff for their patients. We normalize relapses, depression, anxiety, relationship problems, feeling like you're the only one with your problem. And so normalizing sex risk concerns should be no different. Another example, I think this one might have come up directly from our most recent training study, was our treatment program has recognized that sexual risk is a big part of people's drug or alcohol use, so we're checking in with everyone on this topic. So that's pretty powerful, and that's pretty welcoming. Another thing providers can do is to check your own biases. Because our default beliefs are such deeply held beliefs, it's hard to see them and even harder to put them to the side when you're talking with your patients. And a lot of times we don't even recognize when or how our biases affect what we say or think. So it's pretty likely that your initial gut reaction when I say sex is connected to a bias or a default belief that you have about sex. As an example, as I was working on this training project, I had a co-investigator who was a sex educator, and she talked about how her bias was that sex was inherently joyful and pleasurable, and what a contrast this was with her physician friend's bias that everyone's priority should be to avoid STIs and keep your body safe and healthy. So those two would likely have come at a discussion about sex from two really different perspectives. And the tone that they would have set, if you can envision you as the patient are sitting with the sex educator versus the physician, the tone that each one of them would have set on the topic would have been really different. And if you have trouble identifying a bias, you might reflect on this more over time, because sometimes, as I said, they're hard to pinpoint, but it's likely that you have them. So what do you do about biases? One option is, after you've kind of determined what your biases are, you can think about a disconfirming statement, which is a way to set it aside and let yourself hear the patient's own sexual situation, concern, or question. So it might sound something like, on one hand, I believe A, but I can see on the other hand that B might be true for some people. So for example, I believe safety should be everyone's top priority, but I can see how if someone is really lonely and seeking connection, a person might decide to sacrifice that. Another tip that's related to checking your biases is to consider your reaction to diversity and to be curious about it. When we did this training with counselors, it was really interesting how, by and large, most counselors would say, oh, I'm very open, I don't have any biases, I'm ready to listen to whatever patients have to say. But then as we progressed through some of the activities in the study, where some of the counselors had to actually either do interventions or talk to mock patients, it became clear that definitely there were some that struggled with this kind of topic more than others. So providers can ask yourselves, how does sexual orientation or gender identity or choices about multiple partners or any other way people are different sexually from how you might be complicate your discussions with patients? And be honest with yourself. Most of us have some areas where, either because we don't have experience or we don't work with a certain population or we're not familiar with the language, we have some areas of discomfort. So ask, don't assume. People are sexual in so many different ways. Orientation, monogamy, what sex means, who does what, when, how, why they're having sex. You will get much better quality of information if you just ask rather than assume that you and your patients are on the same page. And I do want to mention humility. So there is no single skill or insight that makes discussing sex with patients easy. Like most things that you do in counseling, you just do what you can and you keep doing it. Results are most often not fast, and they're not large, and they're not dramatic, but they can be real and they can be very useful, and they can definitely be cumulative over time. Okay, so I mentioned previously motivational interviewing, and the next set of slides have to do with something that we call MI spirit. So this is not an MI training, and these are not necessarily strict MI skills, but it's a collection of MI themes that we collectively kind of lumped together as a spirit, that if you can channel this spirit, it will go a long way toward helping you be more effective in these kinds of conversations with patients on sensitive topics. So what do I mean by MI spirit? As I said, in the next few slides, there are some basics about MI that I think will be a really helpful framework for you to operate from. So first of all, when you think about behavior change, we all know that just telling someone why they should change, or why they should use condoms, or why they shouldn't have sex with multiple partners at the same time, it does not guarantee that they will make those changes, of course. So this notion that people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the minds of others has been around for a long time. Notice that this was written in 1660, so it's old. MI can be very helpful with sensitive topics like sexuality. It allows you to avoid defensiveness in therapeutic relationships. It reduces the number of arguments between counselor and client, which, by the way, are the best predictors of bad outcomes, which of course none of us want. And MI helps to elicit the client's or the patient's own ideas about changing health risk behavior. And this is no different than using MI with exercise or weight loss or substance use, drinking, smoking cessation. Just throw in sex risk along with all those other topics that we're used to thinking of MI with. So remember, motivational interviewing is collaborative, it's a goal-oriented style of communication, and it's designed to strengthen the person's personal motivation for and commitment to a goal by really drawing and eliciting and exploring their own reasons for change within an atmosphere of acceptance and compassion. So we envisioned this notion of MI spirit as consisting of these 4 different themes in motivational interviewing: collaboration, compassion, evocation, and acceptance. So I would suggest that you don't even need to have attended a formal MI training or an MI workshop in specific MI techniques to understand this spirit of MI and to operate from this paradigm. So taking a look at each one of those parts, compassion is working in the best interest of the client or the patient. So not in your best interest as the provider. It's not a self-serving one. You're thinking solely about what is best for the other person, which may be different than what you think is best. Collaboration is about honoring the patient's expertise and perspectives, by giving them an atmosphere that's conducive to change. Again, this is with things like normalizing statements and recognizing your biases, giving and getting permission, rather than forcing some change upon them. So for a visual, this is really two people sitting next to each other at a table working rather than across from each other. And that's what collaboration is about. Here is just a contrast. In traditional behavior change approaches, we tend to have been trained in the kind of more the confrontation approach, where you as the provider kind of override or see the patient's perspective as being impaired, and that you need to, your job as the counselor is to kind of educate them and increase their acceptance of a reality that the person is not seeing or not admitting. And that is really in contrast to this idea of collaboration that honors where the other person is coming from and where they're at, and you're really a partner with them in that process. The third concept in MI Spirit was evocation, and this is really about drawing forth from the client reasons, motivation, perspectives, goals, values. All of it is kind of coming from within the person as opposed to you educating them about what you think is important. And finally, acceptance. This means that the relationship is based in acceptance and empathic listening, and clients or patients have the final say in what they will do, and you must respect that. So this is important when the person, you may offer them some condoms from that bowl of free condoms on your desk, and they might take them and they might not, and whether or not they use them is entirely up to them. You might have clear ideas about choices that they're making with their sexual health, but they might have different ideas. And so your job is to empower them to figure out, is this really in their own best interest for where their goals are at? And it might take them a while to get there, even though to you it seems obvious. So that kind of gets to autonomy support. So this is a clear recognition of the patient's right and the capacity for self-direction. So they choose, not you. And another contrast, autonomy really affirms where the person is at and their ability to choose for themselves, versus authority, which again is kind of a more traditional approach where you, the provider and the counselor, tells the client what he or she needs to do. So a lot of times, our recommendations are, of course, based in experience or based in really sound research, and we're pretty sure that we're right. But we need to balance that with conveying a belief in the person's ability to choose for themselves. So the MI Spirit also involves bearing in mind an acronym called RULE. And if you have been to MI trainings, this may sound familiar. So the R in RULE stands for resisting the righting reflex. And the righting reflex is our tendency to correct or make right our patient's behavior. So it's kind of telling the other person what to do or what they should do. And we assume the role of the expert in that situation, even though we may be the expert and have their best interest at heart. People just don't like being told what to do. Particularly, I think, our patients. So if we're to help guide them make their own choices, we have to really avoid correcting their behavior. The U stands for understand the client's perspectives and, perceptions and motivations. So again, it's always best to work from where they are, not to get ahead of them and cause them to shut down. It's really important to understand what they're thinking and feeling, and this is achieved by asking, not telling, and then listening closely. So L stands for listen. Reflective listening with some summarizing at various points helps to really clarify that understanding by reflecting back what you think they said or meant, and then allowing the person to either confirm or correct you or expand your understanding. And finally, E stands for empower the client. So this is really, again, supporting their ability to change, and this is done by making it clear that you have every confidence in their ability to change, and also by reviewing and emphasizing any of their past successes. And you need to be genuine here, which can sometimes be tricky. So finally, the last tip for providers that I would suggest is to bear in mind an acronym called SUDs. So this is an acronym for a problem-solving approach that can be really useful when helping patients work through sex-related challenges in their relationships or in their recovery. It's also useful just as a general problem-solving tool too. So you would probably agree with me that a lot of our patients struggle with problem solving in an organized way. They may have a tough time either thinking clearly, being organized, thinking through what they need to do next, and they get derailed easily. So having an acronym like SUDs in your back pocket is a great way to just pull it out in session and walk through a problem together. So SUDs, the S, it stands for stop. Figure out what exactly is the problem. And this is sometimes all you need to do because it's just a big jumble in their head, they're overwhelmed, and if you just take a few minutes to articulate what exactly is the problem, that can be a very powerful intervention right there. O stands for options. Figure out what your options are. Again, sometimes even this is all you need to do. Just identify or clarify what are some of the choices for their next step. D stands for decide. This is just picking one and deciding what you're going to try first. A stands for action. Carry through with that decision that you just made. How are they gonna do it? And then S stands for self-praise. So after they're done, go back, evaluate, give themselves credit for what they did or what they learned. And as I think I might have mentioned, you don't need to do all 5 steps all in one fell swoop. Sometimes just one of these can be very useful. So SUDs can be used to help patients either plan an upcoming situation. Maybe it's a get-together with some people or some interaction that they think that they might have, and it may involve potential relapse risk or a risky sex situation. So you can use SUDs to kind of plan ahead or use it after the fact to talk about what happened and maybe do a redo. It can be used, as I mentioned, just in bits and pieces to elicit ideas for options, decide, and action. And it can really be an invaluable problem-solving approach for almost any situation in recovery. It's really a very generalizable recovery skill. So here we are at a summary of the tips that I've kind of very quickly run through today. The first thing that I mentioned was you can ask permission. And this is really a foundational skill, and you would be amazed at what comes out when you give permission to people to just open this topic. You can use normalizing statements. Again, this is a statement that either you make as a provider or the agency can really set the tone with in terms of their intake materials or their staff trainings. acknowledging that sex risk is an important issue in recovery, and it's something that the treatment program values and will focus on. You can check your biases and consider diversity in the patients that you see. You can approach with MI spirit, which includes compassion, collaboration, evocation, acceptance, and autonomy support, and also remember rule. And you can use the SODA's problem-solving model. So I said to you earlier that we just completed a study where we trained counselors in a more extended way on a lot of these topics and more. And very briefly, that study compared two types of trainings. One was an enhanced training that was about 10 hours that covered a lot of what I've just consolidated for you in 45 minutes. And then there was, it was compared to a very basic 2-hour training. We had 61 counselors across 4 agencies, and our training, the counselors who did the enhanced training showed significant improvements in how confident and competent they felt in talking about sex with patients, in the use of motivational interviewing reflections, which was a measure of listening, and in their use of SODAs and other communication strategies. And these results held up at the 3-month follow-up. So our conclusion was that counselors can learn these skills, they can use these skills, and we got a lot of anecdotal feedback from them that they really appreciated having the practice, and they felt like their own clinical skill set had really been strengthened because they had kind of gotten rid of a lot of their anxiety about this topic that they felt was a really relevant one for their patients. So lastly, here are a few resources for providers if you wanted to increase your own knowledge of online stuff that's out there for patients. There are 3 websites that we list here. Planned Parenthood is very straightforward, very plain information about STIs and birth control, relationships, sexual orientation, etc. Scarlet Teen and Oh Joy Sex Toy are 2 sister sites. They are both a lot of information presented in a much more casual style. There's a lot of graphics, graphics, but also information presented in graphic form, like comics. There are a ton of different topics, and it's really geared toward a younger audience, but it's very educational, and these websites have been vetted, so they are a credible resource. And it might just be worth you checking out just to see what's out there and available for people if you wanted to refer them for more information. So finally, here we are at the end, hopefully not too overwhelmed by all the information that I have presented. And I just want to thank you all for your attendance, and I hope some of you are motivated to try out a few of these things in your practices.
Thank you, Mary. This is very, very fascinating. So thank you so much for sharing your knowledge with us. Before we go to questions, okay, I have to figure out how to do the next slide. Okay, yeah, so before going to questions, please help us to learn from your perspective and give us your feedback. You're gonna get 2 short surveys, one now right after this event and one in a month. And we depend on your feedback to improve and to keep our activities going funding-wise. So please help us out. We are going to start the questions. They can be typed in the chat box, so we'll get them in a minute. Before you go to them, I would like you to know about our next webinar. is going to be in January 23rd, Brief Interventions for Cannabis Use Disorders, the checkup model, with Denise Walker. And let's thank you for your participation. So let's get to questions here. So I have one question for you, Mary. So you talk a lot about the sexually transmitted diseases. How would that apply also for patients in recovery that are maybe thinking about getting pregnant or not taking precautions in terms of getting pregnant in a time of recovery?
So your question is, how do you balance kind of safe sex with wanting to be starting a family?
Yeah, and particularly if the person in recovery is excited about the possibility to starting a family while in recovery. Yes, is that applies to it? That is a common issue that also comes up.
That's, boy, is it a common issue? You know, I'm not sure how often women of childbearing age are wanting to start a family while they're in treatment. But I would imagine if they do, then well, there are many things to consider there in terms of their readiness and those kinds of issues that I'm sure would get discussed in any counseling session. But if it were me and I were seeing this person, I would very much think that was a useful conversation to have, because you get this opportunity to really talk about so many ways in which pregnancy or parenting may or may not be a help in their recovery. I'm not sure if I'm answering the question totally, but I would really see it as a positive discussion to have.
Good. Yeah, no, thank you. I think it is, and there's no right or wrong answer, but I imagine this is a big invitation for us to look at our tendency to write people, because you'll be like, are you, it's like the tendency is to think that's not the time to get pregnant. So how do you listen from the perspective of the patient and understand how that fits or it doesn't fit on their journey for recovery? So yeah, I know that was very helpful. So we are pretty much on time. We have one question here. At what age should we begin to discuss the issues brought in your webinar?
So I'm not sure for that person if you're what age clients you work with, but I would advocate that based on the findings I mentioned about sex education, the studies on sex education, that even if you're working with teens or younger teens, preteens, that it is fair game to ask them about their romantic interests, their whether there's anybody special in their lives, whether they have any anxiety or worries, whether they're getting any pressure from their peers. Really just open the door, because you never know what people are going to say. And not talking about this stuff is a sure recipe for you being in the dark, because I think kids and adults, are a lot more active than we think they are. And I would also mention, if you are a provider that works with teens, then definitely you should check out the Scarlet Teen and Oh Joy sex toy websites. Just so you see if it's worth having that in your pocket to be able to pass on.
Good. Okay, so I will call it done today. Thank you so very much for everything, and we wish to everybody happy holidays.